Good afternoon. And today we have a pleasure of interviewing, that's actually first time, orthodontic coach, Dr. Mike DeLuke. Good afternoon, Mike.
Good afternoon, Maria. Thank you so much for having me on. It's a real pleasure.
And I'm gonna start thanking our audience. If you have trouble sleeping or sleep next to the snoring partner, this program might be for you because we're gonna talk about facial development, what affecting your sleep. And if you're a medical professional, who just like us, so passionate about finding all the puzzle and help your patient sleep well, this program is definitely going to be for you. And first, I want to start with telling you about Mike. We met actually on a conference on American Academy of Physiologic Medical and Dentistry. And I listened to Mike lecture and I thought, wow, that's going to be great for my audience. And then we connect and here Mike is to share his knowledge. But we also, we used to be kind of neighbors. Mike graduated from SUNY Stony Brook and he was a valedictorian. He's actually first valedictorian on our channel. Nobody else mentioned that. And then as the best in the class, he got into the Ortho program and he was a chief resident in the final year. And he is a certified orthodontist. And he also worked with the cleft craniofacial team. That's a very elite area of ortho. And he had his practice for more than 20 years in upstate New York. And now he got into his passion of teaching, and he served on a board of Orthotown magazine. You know, I have a soft spot for anybody who writes or in the editorial team. And also, he's a creator and a host of Doc podcast, where he discussed with his guests about different aspects of orthodontic treatment. So my first question to you, Mike, who is orthodontic coach? We never had orthodontic coaches on our practice. And it's a part of that question. I know as a young doctor, I used to have a very difficult time of choosing my philosophy. And how your work can help freshly graduated doctors, specifically orthodontists, to find their own philosophy of practice, because I think it's a cornerstone of the whole career.
Yeah, I agree. So when as you said, I practiced for a couple decades, my own practice. I started it from scratch myself. I didn't work for anybody. I did it right out of my residency, built it up. So in doing that, in building and running my own practice for 2 decades, I learned a lot. I learned a lot clinically, administratively, a lot of the things that we don't learn in school and we aren't taught. And we're going to talk about some of the treatment sides of those as well during this interview. I also learned a lot on the practice management side and on the financial side, on the running a business side. And I would get so many questions. I was always teaching in some capacity throughout my entire career, but it was kind of a part-time, just a little bit here and there when I could help out, as you mentioned, on the cleft craniofacial team and in some other institutions. And I would get the residents all the time asking me all these business related questions. And then when they started understanding that I understood airway, and we certainly don't learn about airway in dental school or even in orthodontic residency, and they would just start picking my brains and they would start picking my brain. And I just started to think there's a real void that I could fill here. I love to teach. A lot of faculty, unfortunately, it's not a criticism, it's just a fact. A lot of faculty at our institutions have never done this in private practice. They've never had wet-fingered dentists, dealt with, what it's like to be short 2 or 3 team members and have emergencies coming into your schedule and all the bills to pay and all the budgeting and all that. It's hard, right? It's hard. And so I said, well, I've done all that. And I've also been in academia and I love teaching. And I knew I wanted to spend the second half of my career more in a teaching capacity. So I thought, what better way to do it than combine them?
No, that's great. But tell me, from your view, what is the biggest challenge young orthodontists face when they're developing, practice and treatment philosophy?
Yeah, so many, because what happens, and this actually really, it's it's a bit of a sensitive point for me because it's frustrating because what I hear a lot, and it's sad, because as we know, it costs a lot of money and a lot of time to get this education. Orthodontics, for those in your audience, if they don't know, is typically 4 years of college, 4 years of dental school, and 2 to 3 years of a specialty program. It's a lot of time and a lot of money. And these residents are coming out in a lot of debt, like $500,000 or more of educational debt. Or, yeah, I know some are $1 million. I do.
Million. That's very close to the million. People in our area where you used to be, that's the million.
Yeah, sure. And so they're coming out with all this debt, all this financial pressure. And they say to me all the time, Mike, I want to learn from you, or I'm seeking your advice because I want to learn how to do this in the real world. I went through this process just to get the degrees to legally do this, but now I need to figure out how to really do it. And Maria, that is so sad. It is so sad. So their biggest concern is, how do I take everything I've just spent all this time and money learning and actually do it? And we're not sending these residents out prepared sufficiently. They know a lot. They're super smart. They have a super great background, but there's no connection between academia and doing it in an academic setting and private practice. And that is a huge challenge for them. And it's a huge source of stress. And it's something that I've been very, very happy and really have enjoyed helping a lot of young docs and residents navigate that.
That's such a noble mission. But whatever you hear, it's just coming to the right ground, because I actually thought I'm only one who cannot navigate the private practice, who cannot figure out all do that, and who cannot find satisfying first job. I thought I'm the only one. But guess what? Now interviewing people, I realize I'm not alone. And that's a great words for a young generation of specialists. You're not alone in this game. We all got through this. And all this shine and class and style and money and, financial ability, they not there for nothing. They got with it a lot of sweat on their back and a lot of fear inside their heart and stomach turning over and all of that. So I think it's a very rewarding step you did in your career, what you now helping people to do that. I'm going to ask you practical question and start coming more and more. And, on my channel, I interview a lot of physical therapists and some other people who, like myofunctional therapists, who around us, and they deal with the patients who we treat prior to that. So we're gonna talk about MARPE or SARPE. For people who don't know, that's the expansion of the upper jaw. A lot of people hope it's gonna cure sleep apnea. But also we find out recently it's a wonderful treatment and it's not too invasive, and people can accomplish a lot of wonderful things, including the nose breathing, what we are so passionate about, but it can be asymmetrical. And tell me your view on MARPE, SARPE in general, and what people who choose this model of treatment have to take into consideration or do prior to that procedure to prevent unfortunate results.
Yeah, it's a great question, a tough question to answer in a short amount of time, because it is a very deep and somewhat nuanced arena. But I'll try to summarize it best I can. And as you said, there's MARPE, microimplant or mini implant assisted expansion. And essentially, for your audience, most people have heard of expanders, right? You've heard, the thing that goes up in the roof of your mouth, typically glues onto the teeth, and you turn it with a key of some sort and it will expand. And that concept that actually originated back from Lizaroff and distraction osteogenesis. It's this concept that you can grow bone. Well, when you get to be a certain age, the zipper, I call it, in the roof of your mouth, it's like a zipper where the two sides of the face have come together. They get tight and the bone starts to fuse in certain areas, and we call it interdigitate. These think of fingers that start to like intertwine with one another. And if you then hold on to the teeth and crank, it's a lot of force. It's pounds of force when you're turning that key. It can push the teeth out of the bone because the weak link becomes the tooth and the socket the tooth is in, as opposed to the middle, that suture and that zipper that we talked about. So people have come up with different ways to address this. Now, one way that's been around for quite a while is, as you said, SARPE. So that's a surgical assist to that. So what that is you send the patient to the oral surgeon. you have an expander in and it hasn't turned yet, and they go in and they go up through the mouth and make incisions, and they go in and they cut the bone, the maxilla, the upper jaw, and they free it from the base of the skull. And then that, in theory, and some will make a midline cut as well. They'll cut down the middle of it, usually, typically. So they'll cut down the middle as well. And by doing that, you've basically you've kind of tried to reverse the anatomy and make it younger. So you have these free parts that now, when you turn that key, it will expand, right? And you won't tip the teeth out of the bone. But what we found was, because of where those cuts are, so in other words, that works, right? I just want to say that works. It's successful. I've done it in many, many patients. When you do that, however, that was done before we really knew about airway, breathing, the relationship of nasal volume, and all of the interaction between the sinus cavity and nasal passageway volume and airway, and how that plays in. So when SARPEs were being done, the surgical assist, that was really just looked at as, can we get the bone to be more normalized for the teeth to fit together better? Well, because you make those cuts that free up the bone, that's your failure point. So that's where your expansion happens, which means it's pretty low. It's down, at the sort of the ala of the nose, we call it, but the side of the nose, about halfway between, so to speak, the inferior border of the eye and the corners of the lips. So you're not getting as much nose change. So then people started saying, well, what if we could avoid that? What if we could anchor these expanders, same sort of turnkey concept, but instead of anchoring them on the teeth, and instead of going in and doing a surgical cut, what if we just anchored them into the bone, put these little screws into the expander arms? You have a lab make it with little holes and you screw it in. Patient's numb, it's comfortable. And so you put it in. And then some people also make a cut in, called the pisocorticotomy, where they'll make a cut in the middle of the palate as well to kind of free that bone up. And then you just start turning. And initially, most people, myself included, were thinking, what? Like, how's that going to work? But it does. You're actually able, by putting enough pressure on the bone and not the teeth, you're able to take that zipper that we talked about, where you have this interdigitation, think again of the fingers interlocking. By pushing on the bone and not the teeth, you're not compromising the weak link that is those teeth. Some of these appliances still anchor to the teeth, some don't. That gets, again, where it's kind of nuanced. But the challenge is when you do that, the maxilla is not free floating. That is not the only zipper, so to speak, that you're dealing with in a grown adult. There are zippers called the circummaxillary sutures, which is just a fancy way of saying all the other zippers that attach the maxilla to all the other bones of the skull that are at play. So when you turn, yes, you might overwhelm that roof of the mouth zipper. There are other zippers in there, and you don't always know which ones you're going to overwhelm and which ones you're not. And
I love it.
Some of these patients maybe you get a zipper more on one side than the other, up towards the eyes or the nasal bone, where the maxilla, the upper jaw, meets the nasal bone. Maybe one separates more than the other. You really don't have a way to control for that. And it's not that the practitioner is doing anything wrong. It's just, you just don't have control over it. And so there's other procedures. Dr. Stanley Liu, who I teach with at Nova, he is amazing. And he's developed a dome procedure that came out of Stanford, working with Dr. Christian Gimeno. So there's other ways that this can be done. And that's what we're all trying to kind of accomplish here, is how can we do this in the least invasive way for our patients? And the last thing I'll say about that is, many of your audience may be saying, well, why? What the heck's the point? Why? Well, again, the point is if anatomically the structure of the upper jaw is too narrow and the palate is high and vaulted, on the opposite side of that palate, so above the roof of your mouth where your tongue fits, is your nasal cavity. And so if that is all narrow and constricted, it can make it hard. There's more obstruction to airflow going in through your nose, and it can make it difficult to be a nasal breather. So there's more resistance to nasal airflow. So you open your mouth, become a mouth breather, and potentially snore, and then have the sequelae from there. So that's the reason why people are like, why would you ever put screws in there and crank it? It's more than just the teeth. And that gets into a lot of what I deal with too, and why we do this in younger kids, hopefully, so we don't need to be cutting bones and worrying about all that. But the fact remains is, no matter how good we get at catching this early, there's going to be adults who we have to figure out a way to try to do this for.
Yeah, no, this is a beautiful explanation, and I love how you said zipper, because on my channel we have a different specialist, like I mentioned, and for osteopath or physical therapist,
Mm.
it's not really, depends, of course, on the training of a specialist. They not consider it set zippers.
Mm-hmm.
They do certain movement with those zippers,
Mm-hmm.
and muscle attached to those bones, what part of those zippers, and some muscles can have certain tension. So
Mm-hmm.
there are a lot of things into consideration. And I recently, I discussed it, and when, we all have social media, and when people talk about on the social media and they have a great results, so that's rewarding, but asymmetry become a real issue as more of these procedures become in the real life.
Yes.
But I want to talk to you, like my last question would be about evolving concept, how you integrate evolving concept like airway focus orthodontics and myofunctional therapy, which is so close to my heart, into your coaching approach. How do you raise the orthodontist of the future, or better specialists who want to become orthodontist of the future?
So I would,
like,
sure. Yeah. I would be willing to bet that if you polled graduating orthodontic residents in any given year, I would say, not a scientific study, but just saying to take a guess, an educated guess, I would bet 95% probably don't know what myofunctional therapy is, couldn't explain it to you. And remember, as we just talked about, these are people who have gone to school for a very, very long time and are very intelligent. It is not lack of intellect or lack of time spent studying. It's because they're not being exposed to it. So I first just try to educate people on what this even is. So let's first take it from the early treatment standpoint. So why are we concerned about this? Well, young kids are supposed to, all of us, but especially young kids, should be breathing through their noses, and they shouldn't be snoring. And we don't talk about that in the orthodontic arena in our educational in our educational programs and process. We talk about the teeth. We talk about how the teeth fit together. We don't talk about the nose and the craniofacial complex and the dysmorphism. We learn things like adenoid facies, which is a term that's been around since 1870, talking about when you don't breathe through your nose, in this particular case, because your adenoids are too large, the whole shape of your face changes. So what we're trying to do now is raise awareness of this when patients are younger, because we know that snoring or sleep disordered breathing, which is a spectrum of disease from snoring, mouth breathing to obstructive sleep apnea, it doesn't have to be full obstructive sleep apnea. It can be earlier in that spectrum, that there are significant negative sequelae and consequences, not only on the way the face grows, but on cognitive development, neurocognitive development, and behavioral development. So, and that's very clear in the medical literature. So if we can get in there younger and do something about this, great. Well, what do? Well, we just talked about using surgical methods or using bone anchors to expand the palate. Well, when you're little, right, even technically anything under 12, you could make the argument on the bone and how fused that suture is, but you can even expand it up in 15, 16 in some kids without having to get too aggressive. That zipper can move a little more freely. But let's go a little earlier than that. When they're 6, 5, 4, 7, it's really easy. That suture's really, that zipper, the sides of that zipper, it's like a zipper on your coat that you haven't started to zipper up yet, and it's kind of resting across your chest. It's open. It's wide open, right? So you can go in with very comfortably and very easily help those two sides of the jaw. And then all those other zippers we talked about, they're all open too. So you can go in and help them grow. Okay, here's the problem. Some of these kids, especially I noticed in my patients as they got a little older, like let's say they didn't come to see me until 8, 9, 10, all those years of aberrant growth and all those years of craniofacial dystrophy and changes in the way the face grows, just like anything, if you sprain your ankle, you walk a little differently, right? So if you have a sprained ankle for the first 10 years of your life, you are going to have a lot of muscular compensations built in there that, okay, you get your ankle fixed, but now all of a sudden your other leg doesn't function properly, and your hip is out of joint, and your knee is bothering you, back problems, et cetera, et cetera. Everyone's had an incident where they hurt one part of their body, and then all of a sudden, like the nearest joint starts to hurt. Well, why? You're compensating. And that's where the myofunctional therapy side comes in, because that helps work out those muscular compensations that these patients have been inherently building in to be able to breathe, essentially, and oxygenate and be able to grow and develop the face in a more normal fashion, because of the fact it grew abnormally for all this time. And the last thing I'll say is, I found a lot of my cases, if I got them early and was able to help them grow, not that myofunctional therapy isn't necessary, it can be very necessary, but more of those patients self-corrected or needed very little intervention. As they get older, I would go in, I do my part to expand them, help them grow. And the stability wasn't the same. The lip posture wasn't the same. The tongue swallowing wasn't the same. And so again, that's where it's that team approach with not only just having the structural correction, but the muscular attachments to be redirected in their function.
Thank you very much, Mike. You're such a vivid explainer, great teacher. So we really appreciate you, and I recommend for people to listen to your podcast, Doc Podcast, and learn about Ortho Secret, what every patient and provider should know. And we're looking forward to collaborate with you more. Thank you.
For sure. Thanks so much, Mary. I really appreciate it.